Hey everyone, and welcome! Today, we are jumping straight into the essential clinical protocols for two of the most common conditions you'll see in gynecology, bacterial vaginosis and vaginal candidiasis. Let's get right to it.
All right, welcome to Smart Stuff, where we get straight to the high-yield info you absolutely need to know to crush your exams and shine on the wards.
So, are you ready to finally master the vaginitis protocol specifically for your Nigerian O&G primary exams? I thought so, because that's exactly what we're about to do. We're going to break it all down into clear, memorable steps that you can actually use.
So here's our game plan. First, we'll hammer down the core BV regimens. Then we're going to switch to a flowchart approach for candidiasis. After that, we tackle those tricky special populations that always seem to pop up on exams. And we'll finish it all off with a rapid-fire review to make sure it all sticks. This whole thing is built for maximum retention.
Okay, first up, bacterial vaginosis. You know, these treatment regimens are your absolute bread and butter. You have got to know these cold, forwards and backward. Let's break down your top 3 first-line treatments. Option 1 is the workhorse, oral metronidazole, that's 500 milligrams twice a day for 7 days. Simple. Then you've got your intravaginal options, right? You can do metronidazole gel for 5 days or clindamycin cream for 7 days. Notice the different routes and durations? Yeah, that is a classic exam detail right there.
Okay, so what if those first-line options aren't going to work? What's your plan B? Well, you've got oral clindamycin or clindamycin ovules for a shorter 3-day course. There's also the single-dose oral option of secnidazole. And of course, there's tinidazole. Knowing these alternatives really shows you have a deeper level of understanding.
Now listen up, because this is a massive clinical safety point and a total favorite for exam questions. Both metronidazole and tinidazole can cause a nasty disulfiram-like reaction with alcohol, but the key here is the timing. For metronidazole, you tell your patient to avoid alcohol for 24 hours after the last dose, but for tinidazole, it's way longer, a full 72 hours. Do not get those mixed up. All right, let's switch gears. Section 2, vaginal candidiasis. For this one, we're going to think like a clinical algorithm. We're using a flowchart that'll take you right from diagnosis all the way through to management. This is all about smart decision-making.
These first 2 steps, they are everything. Step 1, you diagnose, right? Based on the classic symptoms, confirm if you have to. But step 2 is the critical fork in the road. You must figure out if the case is uncomplicated or complicated. This one decision is going to dictate your entire treatment plan from here on out.
So what exactly makes a case complicated? Just remember these 5 triggers. If your patient has severe symptoms, if it's a recurrent infection, and that means 4 or more episodes a year, if she's pregnant, if it's a non-albicans species, or if she's immunocompromised, boom, you are officially on the complicated pathway. Memorize this list.
Now let's see how that plays out. For a straightforward, uncomplicated case, it's easy. A single 150 milligram dose of oral fluconazole, and you're done. But watch how the treatment ramps up for complicated cases. If it's severe VVC, you're going to add a second dose 72 hours later. If it's recurrent, we're talking a full induction phase, then 6 months of weekly maintenance therapy. You see, the intensity scales up based on the category.
Okay, welcome to the gauntlet. This section is all about those specific, tricky scenarios with special populations. These are the questions designed to see if you can apply the rules when things get messy. And believe me, they are extremely high yield for your exam. Pay very close attention here. This is a crucial one. For BV and pregnancy, oral metronidazole is perfectly safe and actually preferred. But, and this is a big but, for VVC and pregnancy, you must avoid oral fluconazole. That's a huge no-no. The standard of care is topical azoles, like clotrimazole or miconazole, for a full 7 days. This is a non-negotiable safety point. And just a few more quick pearls for BV. What about breastfeeding moms? Standard doses of metronidazole and clindamycin are generally fine. Sexual partners? Nope. Routine treatment is not recommended. It doesn't really help with recurrence. And speaking of recurrence, if that BV just keeps coming back, you need to be thinking about suppressive therapy, something like metronidazole gel for 4 to 6 months.
We're almost there. We're in the home stretch. It is time for our final quick-fire review. The goal here is simple. Sear these critical numbers right into your brain. You ready? Let's go.
7. That's 7 days, the standard course for oral metronidazole in BV.
150 milligrams. That's your go-to single dose of fluconazole for uncomplicated candidiasis.
4. 4 or more episodes per year. That's what defines recurrent VVC.
6 months. The duration of that maintenance therapy for recurrent VVC using weekly fluconazole.
6 months. And we'll end on this. You've now mastered the numbers, the drugs, the protocols, but I want to leave you with this question to think about. Beyond just memorizing this stuff, how does understanding the why behind these drug choices, the pharmacology, the patient factors, how does that change your clinical approach? Because that, right there, is the real leap from being a student to being a great clinician. Thanks for locking this in with me today.